Hey, it's Carmen again. This is my second drug we're going to talk about today, and it is the famous Amiodarone. Boy, this one is a hard drug, and for many reasons. Yes, it's in the ACLS protocol, and you can do a lot of stuff with it, but it also has a lot of side effects. So we'll get into those. Okay, get my notes. I've got to get my spectacles on here. All right, the category. The category is an antiarrhythmic agent class 3. Yeah, I don't know. It's a class 3. It's just it's used in the ACLS algorithms, and I've seen it where you just give it whenever you see something like AFib, or not AFib, but VFib or sustained VTAC and all that. It just slows down the QT segment, and it's a good drug for that. So labeled uses. Labeled uses. Pulseless VT and VF. We know that. Prevention of recurrent ventricular arrhythmias. You probably knew that too. VF or hemodynamically unstable VT. Yeah, we went through that algorithm too. And then the fun ones, the off-label uses. Conversion of AFib, which I don't see that much, but okay. Conversion of SVT, both of which are new onset after cardiothoracic surgery when other therapies have failed. So I guess after the diltiazem and after the Corvert, I mean, they might be trying that, but especially after heart surgery, and they go into this new onset AFib, aflutter. Apparently, it's not the drug of choice, but it works if nothing else works. The mechanism of action. It inhibits adrenergic stimulation, alpha and beta, blocking properties, affects sodium, potassium, and calcium channel blockers. No, calcium channels. Prolongs the action potential and refractory period in myocardial tissue, so it works right on the heart tissue, and decreases AV conduction and sinus node function. It binds to protein. Over 96% binds to protein. So if you've got someone with low albumin, then you've got to get some protein into them so it'll actually work. Where is it metabolized? Take a guess. The liver. It's metabolized by liver with possible enterohepatic circulation. In other words, it goes, once it's in the liver, it goes around and around and around. And it's excreted in the feces and urine. So, reversal agents. They say epinephrine. I can't find anything else. So, if you've got, pretty much before you use the epinephrine, you stop the drip. It's pretty easy. Release date. It was released December 24th, 1985. Almost a Christmas drug. The pricing. It's not a big deal. It's generic. It's been out for a while. And so say you're giving just the IV pushes, 150 milligrams per 3 cc's is $1.69. That's pretty good. The drip, the 900 milligrams in 18 cc's, and then they put it in, you know, how they dilute it, and then you give like 0.5. Anyway, it's $17. There's a brand name, Nexterone, and for 150 and 100 cc bag, it's $41.63. So anytime you get a name involved, you get more money. So anyway, safety concerns. There's a lot of them. I might go back to that after I do some of the contraindications. Try to use a central line. I never thought that it was bad on peripheral lines, but you know how the inline filter comes with the bag, and I always change it out whenever you change the tubing and all that. But that is used to control the phlebitis, because apparently if you don't use an inline filter, especially on a peripheral vein, it causes phlebitis. So just monitor for that if you do in fact have to give it in a peripheral vein. The Beers criteria. I didn't have a chance to research exactly what Beers criteria is, and it was mentioned a couple of times. So if you want to Google that and see who Beer is. Beer's criteria says that this drug should not be given to patients over 65 age or older as a first line drug of choice for AFib, unless the concomitant heart failure or substantial left ventricular hypertrophy. And it has to be related to increased toxicities compared to other antiarrhythmics. So I think basically what that says is if you've got an older individual, you should use another therapy. And maybe it's because of how they metabolize in their liver, or based on what their heart muscle is already doing because they have heart failure. And if they have left ventricular hypertrophy, it could have increased toxicities. That's what I got from it. So the contraindications. If you're sensitive to iodine, if they have an allergy to iodine, I would suggest doing something else. It might be one of those category C things where, you know, you might have to monitor and all that. But severe sinus node function without a functioning pacemaker. Because if you Brady him down, the pacemaker might take over and or defibrillate them to another rhythm. So that bradycardia causing syncope without a functioning pacemaker, and hepatitis, their liver function isn't really good. Pulmonary interstitial disease, so if their lungs aren't that good, or if they have thyroid dysfunction. So those are all things that you have to consider when you're given this drug, especially as a drip. I'm going to go back to safety concerns because there's just quite a few things that you need to know about this drug. It can cause bradycardia and hypotension. That kind of goes hand in hand. Hepatotoxicity, just because once it's in the liver, then, I was telling you about it cycles through again and it can get really toxic. And it can also lead to torsades de pointes if your electrolytes aren't where they need to be, especially if they're deficient in magnesium. And I'm not just saying low normal. Oh, he's low normal. He's like 1.3, 1.4 on magnesium. Sometimes for patients, you have to be like on the high end of normal, and you really have to look at their potassium and their magnesium. I had a patient that had, it was normal potassium, magnesium, phosphorus, everything was in the normal range, but for her, being on an amio drip, it needed to be higher. She'd go into torsades, and we'd start pumping on her chest, and she'd wake up. She was intubated. She couldn't talk, and so I'm very sure it was scary to wake up and people are on top of her. So anyway, so I told you about that. Oh, bottom line, watch TSH levels because they could have hyper or hypo problems with their thyroid, and that will mess with amiodarone. Get the potassium, calcium, magnesium, and phosphorus levels checked and make sure they're well within the normal levels, because if you have low normal, that's not good, and it affects the binding. Also, cardiac devices have thresholds. Yes, they do. I've kind of talked with you already about that. You don't want to be shocked. So just make sure that you're starting IV and you get shocked because they bradyed down or went into VFib or something like that because of low electrolyte levels, and then it made it go off, a functioning defibrillator go off. And do not give to Wolff, Parkinson, White patients because VF might result. So, drug interactions. There were a whole bunch of them. And I tried to get it down to things that are commonly found, commonly what we give, and what people might be on home medications. They might be taking a statin or something like that. So I thought that you might want to know that. Any antiarrhythmic class 1 like procainamide or quinidine, that is an X. Don't give that with amiodarone. The one I was kind of surprised about was a Z-Pak, azithromycin. We give that IV a lot, and that is contraindicated. You don't give that together. Cardiac glycosides is a category D, as well as cimetidine, colchicine, Cerebix for you neuro nurses, loratadine, lovastatin, any statin, don't give while they're on an amio drip. Tizanidine, that's a muscle relaxer, and warfarin. Now, if they have to be on warfarin, you have to reduce the dose 30 to 50% if you have to have them on warfarin. And the weird food one is grapefruit juice. It is a category X. Do not give or do not let them drink grapefruit juice if they're on amiodarone. And I'm very sure this isn't the critical care setting. It's after they're on oral amiodarone and they're at home drinking their juice. So watch all statins, and most all of the HIV, AIDS, those ones that end in Vir, blah, 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 Vir. I couldn't say them all. They're all protein binding, so don't give while taking amiodarone. And believe me, I went through pages, 6-7 pages of fine print of all these drugs that are categorized, and I wanted to, C category, you monitor. So that's not going to affect us, really. We monitor anyway. But the D's and the X's, those categories I wanted you to know about, because that's something that sometimes you don't really think about. I think that's it. I tried to make it quick. The basics of amiodarone. So that's my second drug. Like me, post comments down below, subscribe to my channel, and I got to figure out what drug to do next. So maybe put that in the comments, and then I'll know where to go from there. Otherwise, I might go alphabetical. I don't know. So anyway, talk to you later. Bye.